Hi, everyone. Thank you all for joining. Today, we have the great honor and privilege of having Dr. James Mulshine. Dr. Mulshine is a professor at Rush University, where he served as Associate Provost and Vice President for Research, while also acting as head of the Rush Cancer Center for 2 years and Dean of the Graduate College for 6 years. Internationally recognized and expert on lung cancer, his research concentrates on application of quantitative CT to enable efficient early lung cancer detection. He has been awarded 12 patents and has over 350 publications. He's also received numerous national and international recognition awards, most recently including the Aescylusus Award from the Bonnie J. Addario Foundation in 2018. Dr. Mulshine is also on numerous editorial boards, as well as national and international scientific and foundation advisory boards, including serving as Vice Chairman and Scientific Director of the Preventive Cancer Foundation. He will be joining us to share his expertise on lung cancer. Dr. Mulshine, thank you so much for your time and your willingness to be here with us.
Well, I'm delighted to be here, and I'm really impressed that your colleagues are willing to spend their Saturday afternoon talking about such things.
We're really excited and honored to have you. So to introduce myself and my team, my name is Priyanka Senthil, and with me I have Anish Gugilam and Drake Wong, and we are part of the American Lung Cancer Screening Initiative, or ALCSI for short. And so we're going to take a few minutes to share about our organization and introduce lung cancer and lung cancer screening. ALCSI is a 501c3 nonprofit that works to raise awareness about lung cancer screening. We are a team of about 200 students and doctors located across the United States. And we do the work that we do because lung cancer is the deadliest cancer in the world, causing more deaths than breast, prostate, and colon cancers combined. Lung cancer causes about 380 deaths per day in the US alone. Lung cancer is very fatal because currently many patients are being diagnosed at a late stage when the cancer has grown and spread to other parts of the body. Lung cancer screening is an effective imaging technique that can be used to screen for lung cancer and has been shown to catch lung cancers early. However, less than 6% of people at high risk for lung cancer are currently getting screened. The screening rate for lung cancer is much lower than the screening rates for breast, cervical, and colon cancers, which are about 70%. We believe that educating people about lung cancer screening is one of the most important and effective ways to increase the lung cancer screening rate for populations that would benefit from lung cancer screening. So far, we've given over 250 presentations on lung cancer screening to universities, hospitals, medical schools, and organizations around the US, as well as India, Canada, Brazil, and Mexico, reaching over 10,000 people. Over the last year, we've worked with over 340 mayors from every single US state to issue proclamations recognizing November as National Lung Cancer Awareness Month. And we've also had the opportunity to work with several leaders at the state level, including multiple mayors, Arizona State Senator Lee Laston, who's a lung cancer survivor, Pennsylvania Governor Tom Wolf, and Lieutenant Governor of Colorado, Diane Primavera, to issue public service announcements emphasizing the importance of lung cancer screening. And in addition to our education, outreach, and advocacy efforts, we recently started a podcast series to share the personal side of lung cancer and provide a platform for lung cancer survivors and experts to share their stories. ALCSI also worked with US Congress members and senators to draft and advocate for the first ever House and Senate resolutions, recognizing the importance of the early detection of lung cancer through screening. And in December 2022, the US Senate passed a bipartisan resolution for the third year in a row, designating November 2022 as National Lung Cancer Awareness Month and expressing support for the early detection and treatment of lung cancer. Senate Resolution 863 expands on previous resolutions by emphasizing the need for efforts to increase awareness of screening among veterans, women, and racial minorities. ALCSI also actively worked with Representative Brendan Boyle and Senator Tina Smith to draft and advocate for Catherine's Law for Lung Cancer Early Detection and Survival Act of 2021. Lastly, we want to end by talking a little bit about lung cancer screening. Lung cancer screening is done using a low-dose computed tomography scan. This scan uses low radiation doses, is pain-free, and takes less than 5 minutes to complete. The United States Preventive Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. And right now, they recommend that people between the ages of 50 and 80 who have a 20-pack-year smoking history or more, and who currently smoke or have quit in the past 15 years, get annual low-dose CT scans. 1 pack year is defined as smoking on average 1 pack a day for 1 year, and therefore 20 pack years can be met in a multitude of ways, including smoking 1 pack a day for 20 years or smoking 2 packs a day for 10 years, for example. If you know anyone who might be eligible for lung cancer screening based on the criteria discussed, please encourage them to take our lung cancer screening eligibility survey so that they can learn whether they are eligible and have the opportunity to connect with our team at ALCSI to guide them through the screening process. And finally, we want to highlight that there are other risk factors for lung cancer in addition to smoking, such as exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. It is important that we recognize these additional risk factors because a large number of people in the United States who have never smoked still get lung cancer. So thank you all for listening to that quick introduction to lung cancer screening. And without further ado, we can jump right into the podcast. We have a few questions prepared for Dr. Mulshine, but we'll also have a Q&A session at the end with questions from our live audience. So first off, Dr. Mulshine, could you please tell us more about yourself?
Thank you. Thank you for your kind introduction, and thank you for all the things you've done for people at risk for lung cancer. I am a thoracic medical oncologist, which means I'm a cancer doctor who's been trained basically in medical oncology, who's focused for the last 40 years has been in thoracic oncology. I trained in my cancer medicine. I trained in medicine at the Cleveland Clinic. I trained in thoracic oncology at the NCI intramural program, and I moved to a branch that was the NCI lung cancer branch, which originally was at the VA in downtown DC, and then moved across the street from the main NIH campus to Naval Hospital Bethesda. And I was at the NCI for 25 years prior to coming to Rush. And at that time, I spent my time working with a multidisciplinary team on lung cancer translational research. My focus was development of protocols for stage 3-4 non-small cell lung cancer after about a decade of beating my head against the wall with trying to make inroads with advanced disease. I shifted my focus to earlier stage disease. This was facilitated. We were working on molecular diagnostics for early detection and sputum-based diagnostics and whatnot. But in 1999, there was the article by Henschke and colleagues from LCAP that thoracic CT could be used to routinely find early stage 1 lung cancer. I was working with a variety of companies at the time, did technical assessments, basically confirmed that the findings of the ILCAP group, if true, was going to really fill the space of early detection for lung cancer. The reason for this is because CT scanners are available throughout the world. They're actually available in the United States at an excess capacity of about 70%, which means in order to deal with the population for this disease with a new test that takes as brief a time as Priyanka, you outlined, there was essentially already capacity to do it. And so from a business perspective, the molecular diagnostic companies that are working with said, basically, if the infrastructure is already in place and it's updated every 5 years because of depreciation and other capitalization rules for taxes in the United States, so it's paid for itself. It's paid for by hundreds of uses of CT scanners and ambulatory and hospital bases already. There's no space for a new technology that's going to require, and any new technology that comes into place will require billions of dollars to create a national infrastructure so it could be available for everybody else. So they basically said that the diagnostic imaging industry could give away lung cancer screening for the foreseeable future, thwarting any kind of emergence of any commercial product in the space, and they would still be profitable. And so from a pragmatic perspective in 1999, I basically said, if this is going to be it, let's work with it and figure out how to do it right and well and equitably and in a public health kind of sensibility. So that's how I got involved in early detection, been involved ever since, had the privilege of working with a number of directors at the NCI in terms of, the antecedents and ultimately to the execution of the National Lung Screening Trial, working with Andy von Eschenbach and prior to that, other previous directors. And it's been quite an interesting twists and turns. Priyanka, I'll come back to one of the other comments you made, and that is the fact that there's only a low penetration of screening uptake at this point in the United States. And some people say, well, if this is any good, everybody'd use it, so it must not be any good. And it's kind of frustrating in a way. But the reality is because I've been involved in early detection research at a global level with within the NCI and stuff like that, breast cancer screening went through the same very slow evolution. And it wasn't until, the involvement of Betty Ford and Nelson Moore Rockefeller's wife and stuff like that with breast cancer that the public really started taking breast cancer screening more seriously. And that was, decades after the initial randomized trial result that demonstrated that mammography reduced breast cancer related mortality. So there's a certain amount of inertia that's inherent in bringing new services forward, especially in a disease as complicated politically and economically and socially as lung cancer. And we think it's actually a stellar screening service. Now, that doesn't mean it's perfect, and that doesn't mean it's not going to get better. But in terms of being painless, being already deployed, being relatively inexpensive, it's probably about $300 in charges to Medicare to get it done. For an institute to do a lung cancer screening, so at your local lung cancer screening site to do the incremental next screening is basically about $10 or $15. So it's from a public health perspective, it's a tool that has lots of characteristics that conform with what we expect in terms of something that's going to be able to grow and be an infrastructure of public health throughout the United States and throughout the world. Not to say it's going to happen immediately, but it makes sense. And we'll talk about how some unexpected public health applications of thoracic screening are already emerging as we go through the presentation today. Okay.
Could you talk a little more about how exactly low-dose CT works?
Yeah. Okay. Yeah. Great question. So CT is a three-dimensional X-ray study, right? And so why does CT work so well in chest X-ray, which they studied for decades, doesn't do such a great job? And I hope you can relate to my very simple models. And I don't have a bunch of slides, okay? But when you take a chest X-ray, typically you're doing a PA or an AP. You're either going anterior to posterior, posterior to anterior, okay? And so you're going across the chest. Well, what's the problem with that? Well, there's a lot of stuff in the chest. And so whatever is screened by ribs, by blood vessels, by other structures within the lung is kind of obscured for any kind of APPA type visualization. So we know a priori about the third of the volume of the chest is not assessed by a standard old-fashioned chest X-ray. So if you're trying to assess 100% of the lung and you can only see 2/3 of it, that's a challenge. Now, the business with CT and CT technology is, developed in the 70s, and Hounsfield and others working on it, a Nobel Prize from the conceptualization of this three-dimensional type of imaging. Basically takes slices, it's like bread valves, bread loaves through the chest from top to bottom or bottom to top, whatever it is. And then the algorithms allow the slices to be constructed and rendered in 3D. And when it's done that way, you can visualize the entire contents of the thoracic cavity at fairly good resolution. And the resolution, the precision of what you're seeing, is a function of how tight the slices are. If you only slice through every couple inches, you try to put it together, anything that's smaller than a couple inches is not going to get worked out well. You're not going to see it too well. But if you have 1 millimeter or 7.75 millimeter slice thickness, so you really got ultra fine cuts through, you put it together, and with modern computer capabilities, we have the horsepower to kind of do this very rapidly. We can do it and move it around any way we want. And it turns out surgeons love it because they can anticipate their operative field and stuff like that. But from an early detection perspective, it can visualize the periphery of the lung. And the periphery of the lung, we know, is where the filtered cigarettes come to die and settle out in the airway. And so the vast majority of lung cancer seen today in clinics across the world with filtered cigarettes, the particle size is small enough that it just drops just before it enters the alveoli. That juxtaveolar space is where the peripheral cancers, that's where the topical carcinogenesis from combusted tobacco products settles. In the old days, when they smoked unfiltered cigarettes, they had much bigger particle size and it would land centrally. So you had a much bigger problem with central squamous cancer. As filtered cigarettes in the 50s, 60s with the modern manufacturing processes and stuff like that became dominant, it moved peripherally. Periphery of the lung is well visualized because when you actually get out of there, out to the neighborhood, and because of the precision of the 3D rendering possible with CT, you can see those alveolar structures, not at a microscopic level, but at a macro, very small level. So you can visualize very readily what's going out there, because the lung, after all, is a balloon. It's an air-filled structure. So there's really not, you have the ability to refine small structures in the periphery of the lung with exquisite resolution. And that's the whole magic. And, oh, by the way, you also see the parenchymal structure of the lung, the architecture of the substance of the lung, and what the peripheral airways and bronchioles and stuff like that are sitting out in the periphery, the loads of grapes, and you can see all that. And so for the purposes of lung cancer, you're looking at small emerging non-calcified nodules. You can see that great. For purposes of emphysema, and emphysema is destruction of the peripheral structure of the lung, where the alveoli, and alveoli are little grape-like clusters. You see them all in anatomy books in your early classes and stuff like that. And you hear about the elastic recoil of the lung, and the lung is just a big bilge structure, and the alveoli is the end of it, and that's where the air exchange goes on. So everything's pulling into the alveoli, and then through elastic recoil, it's being released. And so the lung, the inspiration, expiration is facilitated by the anatomy and physiology of the lung, with the arborization of the bronchi to bronchioles out into the alveoli and then back out. And it's the recoil actually serves to facilitate the expulsion of air so that it can deal with the next vacuum formed by the skeletal structures of the axial skeleton. Well, with cigarette smoke, you get compromise of all those things. We'll talk a little bit more about that. But basically, you're talking about the happenstance that the characteristics of CT reconstruction of small structures turns out to be exquisitely useful in this context of where tobacco settles in the lung relative to early detection of stage 1 lung cancer. And it just it turns out that way. No one was thinking about it. Empirical found out worked. And then when you think about it, it makes sense.
So one of your major research focuses is CT-derived emphysema. For those that don't know, could you first explain what emphysema is and then talk about the number of people affected by emphysema?
Now, sure. Let's put this in general terms, okay? I'm going to use a model of arthritis, and we'll bring it back to lung cancer, okay? Or emphysema, okay? Everybody knows that you get arthritis because the ligamentous structures that anchor the joint that allows you to bend your finger get compromised. And in rheumatoid arthritis, the sense is that there's some kind of impetus, there's chronic inflammation, there's release of proteolytic enzymes. The proteolytic enzymes, the cartilaginous, ligamentous structures and stuff like that. And when you lose the anchor, your joint doesn't work anymore, okay? So that's a pretty, simple model, and we understand that. Well, emphysema is rheumatoid arthritis of the alveoli, okay? Because the alveoli is a bubble. Well, how does the bubble happen all the time? Well, that happens because that anatomic space is covered with surfactant, and surfactant's basically a phase conditioner. It's a lubricant that keeps that moving nicely, okay? And so when you pull in your breath by anatomic constraints, the alveoli pulls open. And because it has that surfactant lining, the fluid lining, just like there's joint fluid that keeps your joints nice and working, there's fluid that keeps the alveoli opening. And its supported scaffolding is a ligamentous, cartilaginous, kind of structure that's roughly equivalent to what holds your knee joint or your finger joints, okay? Well, again, when there's chronic inflammation in the peripheral airway related to the deposition of tobacco combustion products that are not completely burned, that's like throwing gasoline on the fire, and you get chronic inflammation. And if you get it in the airway, we call it bronchitis. That's part of the COPD spectrum. If you get it in the periphery, what happens there is the release of the proteolytic compounds breaks down the parenchymal substance of the lung that anchors the alveoli. So instead of having a bunch of grapes, you just have a big old pocket. And a big old pocket, as opposed to a bunch of these fine clusters, relatively inefficiently transfers oxygen. And it also does not expel things the way that you get with the normal respiratory movement. So you just get a big old bag, and you're not moving air. And going from perfect alveolar structure to a big old bag is emphysema. It can be mild, it can be moderate, it can be severe, depending on the extent of destruction of the normal composition of the alveolar ecosystem, okay? Now, how do we measure that on a CT scan? Well, it's an X-ray again, and you're measuring electrons moving through the substance of the lung. And when the alveoli are in their normal structure, there's a certain amount of substance there. As that gets destroyed through this pathological process of emphysematous destruction, the electrons just go through because there's nothing there. It's just a big boggy space. And you get, blebs, which are big empty spaces where there used to be alveolar structure. So radiologists visually or with computers can measure either, relatively speaking, a lot, moderate or severe, or with much more sophisticated algorithms, how much attenuation of the X-rays goes on as it crosses through a volume of the substance of the lung. And that's basically emphysema with emphysema detection through CT.
That was a wonderful explanation. Thank you so much. I think that really helps. So for individuals with lung diseases like COPD and emphysema, they can be at an increased risk for lung cancer. And so can you talk about how CT-derived emphysema findings can help in selecting high-risk individuals for screening?
Okay, so thank you. This is the mother lode. This is why thoracic CT is not just lung cancer screening. This is why this is tobacco-related disease screening, or this is a visualization of the inflammasome of someone with a chronically diseased lung, be it due to tobacco smoke, diesel fuel, nickel toxicity, radiation, or whatever. The chronic inflammation that goes on in the lung kind of, has stereotypic kind of destruction. So as we were discussing, 85–90% of emphysemas, lung cancer and emphysema are both about the same, 85–80% from smoking. But if you're a smoker that happens to live in an area where there's a lot of pollution and this, that, and the other thing, it doesn't help. It doesn't vaccinate you against lung cancer. So what I'm trying to say is the technique right now we're focusing on lung cancer is very important because it's a focused high-risk use case. But this is going to be applied generally as we get better at it. It's going to be applied generally for all kinds of early lung disease. Now, lung cancer, the spectrum of emphysema, COPD, which we can come back to if you have questions about, but there's kind of, you know, if you get a certain amount of this, we call it emphysema. If it affects the central airways, we call it COPD. But in pulmonary, they just say it's a spectrum, it's a continuum. So it's not different, it's the same pathological process manifested in different compartments of the lung. So cigarette smoking, the crystallization of combusted tobacco components, we've already talked about that can land in the periphery and cause lung cancer. It can land around the alveoli and cause COPD emphysema predominantly. But that same thing, because you're breathing in oxygen through the lungs, it immediately goes to the heart. And then, you know, the heart does its thing, pumping oxygenated blood to the rest of the body, right? So when you inhale on a cigarette, it's bringing all those particulates with nicotine right into the lung, directly with the next stroke volume into the heart. And then within 8 seconds, you get the first transmission of nicotine from the cigarette to CNS acetylcholinergic receptors, okay? Well, everything along that pathway in a high-risk individual getting lung cancer screening is either at 20 or 30 years of this activity going on, you know, at an hourly basis and stuff like that in their body for all this period of time. So anywhere where this tobacco combustion product has made its way, be it in the periphery for lung cancer, be it in the alveoli for lung emphysema, or be it right through the heart, through the coronary vessels, which get perfused on each stroke volume by that tobacco combustion product rich blood coming through, they all get pathological consequences. Surgeon General, you know, 1967 or whatever, started telling us tobacco doesn't cause one disease, it causes a multitude of diseases. And we're going to talk about the ones in the chest because that's what the CT can see. Well, we know all that tobacco combustion product eventually winds up in the bladder, and smoking is a risk factor for bladder cancer. But, you know, the CT scan that we're doing doesn't see the bladder. So we're just focusing on what is seen within the thoracic cavity. And it turns out 3 of the 4 leading causes of premature death in our society are routinely seen on chest CT. That's coronary artery disease, manifested as coronary calcium calcification, COPD, emphysema, which you talked about briefly, and lung cancer, which I think you know more about, okay? So those 3 diseases you see at the same time. So if we're doing it for lung cancer screening and we're potentially curing lung cancer, we don't say, hey, we've made a great triumph because this person died of COPD or heart disease instead of lung cancer, so that's a yay for us. That's ridiculous. We have a person-centric, patient-centric perspective. We're looking for global outcomes of health. And so if the information is there, we know it's there. And the first demonstration of additional information, we wrote this paper that's coming out next month about in terms of the integration of lung cancer screening and emphysema screening. Over the next year, you're going to read a ton of articles and progressively more going out in time about also the ability to detect coronary calcium in very, very precise and potentially even more anatomically precise longitudinal kinds of ways. And that's where the field is working on right now for coronary imaging. So those 3 things we think are going to be the principal targets of lung cancer screening for the foreseeable future. And that will be a major contribution of public health and worthy of the time of you young scholars, you know, thinking about how to make the world a better place.
Do you believe that doctors in other specialties like cardiology, for example, may be able to help encourage interventions when there are findings of emphysema or COPD on scans?
Yeah. And so think about this for just a second, and I'm going to throw it around a little bit different, but what's a leading cause of death of people who have COPD emphysema? Coronary artery disease. You know, if these things are interwoven triad, you know, people with heart disease die of lung cancer. The most frequent cause of death with with COPD emphysema is first heart disease, second lung cancer. I mean, they're just interwoven. And this is epidemiological data that's 30 years old. This is not new information. So they're interwoven at many levels. There's comorbidity. What we did, I was very much involved in the development of combined modality, small cell lung cancer therapeutics in the 70s and 80s and stuff like that. And we always had to be very careful, because if we gave, cisplatin with, vigorous hydration, that'd be great. The kidneys be fine, but someone would die of fluid overload. So, you're always walking the tightrope in tobacco exposed population of the morbidity of tobacco exposure.
Yeah, thank you for that. I think that that's a really important point, that if we're able to utilize CT scans to not only detect lung cancer but also emphysema and these other lung conditions. But I think a tight integration between cardiologists, pulmonologists, oncologists is so important, because as you said, there's always we're always walking on this tightrope with conditions of the lung. So definitely. And so for a lot of patients, a concern about lung cancer screening is false positives and radiation exposure. So could you please discuss both of these topics and whether they should be major concern for patients?
So if you're medical professionals, and so I think it's evident to you that when we have some of these more advanced tools such as thoracic CT, where we're able to really control the dose, and we assume that our medical radiation, medical physics colleagues and stuff like that are going to make sure that we're not unnecessarily radiating people through sloppy methodologies or inadvertent technique errors or stuff like that. Because, like anything else, I mean, surgery can work, but it's got to be good surgery. Bad surgery doesn't work. Bad radiation, physics in application and screening is a real problem. So we're going to respect that. But the doses that we're using right now in most of the institutions that you would interact with are smaller than the doses that we use for the NLST. And the doses for the NLST was, on average, something like 3 millisieverts. Sieverts. And if you happen to be following thoracic CT, you know that there's right now a recent breakthrough in technology with Siemens has a much better detector system than has been used before. And so they call this a photon counting CT. And these photon counting detectors are much more efficient. So the dose of radiation that they need for the best CT done today is like an order of magnitude less than the dose that's being used in routine clinical practice. And that's probably an order of magnitude less than the dose that was used in the LT. And the radiation safety people and stuff like that looked at this seriously for lung cancer screening when they did the NLST, which was started in 2002, they decided that the dose there for the at-risk population of screening subjects was basically conceptually possible, but not measurable. So it was low enough that they were really not going to be able to assess in someone who's already 50, 60, 70 years old, whether or not there was going to be a radiation exposure caused cancer 20 years later, because that's when they usually happen, when these people are 90. So it's a theoretical concern. And of course, you have to use proper technique and shielding and everything else. But that should not be the driver for why people do or do not choose to get cancer screening. If it was, no one would fly from New York to California, because the doses of radiation are not much different in the typical jet. So radiation is something public's doesn't want a lot of radiation, but I don't think that's the limiting concern here.
So another concern we see in a lot of patients is the concern about false positives for lung cancer screening. So how can we use quantitative imaging to help reduce the rate of false positives?
Yeah. So, again, ideas are hard to move forward And this idea of false positive imaging is kind of a, there's these articles that say, lung cancer screening is associated with 99% false positive. Oh, what does that mean? I mean, what it means is that when they did a scan, a lot of people have schmutz in their lungs. They have spots and this, that, and the other thing. Now, when they did the NLST, what do they call these? They call these suspicious findings. And somebody who didn't like lung cancer screening said, well, all these suspicious findings are false positive. Well, that's ridiculous. Lung cancer is a pathological diagnosis. That means somebody looks under a slide and says, that is malignant lung tissue, okay? That's like saying, I have freckles on my hands, so that's melanoma. And so if you have a lot of freckles, that's false positive melanoma. That's ridiculous. So it's very clear that the lungs of individuals who have smoked for 20, 30 years have all kinds of little stuff, resolved pneumonias, this, that, and the other thing, dried secretions that collapse and can form pseudotumors, insipated areas and stuff like that. And you scan the person a week later and it's gone. And that's not false positive cancer. So when you really get down to it, the best articles to help for this are like the articles that were done with the people right after they developed the LungRADS approach for classifying findings on CT. And they basically took the American College of Radiology approach to mammography, they adapted it to lung cancer, and now have LungRADS, 1, 2, 3, 4, whatever. And there's a category of suspicious, that needs diagnostic workup. That's about 12% of cases. Now, if you use quantitative techniques and you actually go back and look at those places 3 months later, 6 months later, whatever the protocol is, and you see if it's growing or not growing, that's an even better approach, but that's a research approach. So in routine clinical practice using LungRADS, the ceiling for false positive diagnosis is 12%. That's really pretty good. That's better than colon cancer, lung, and breast cancer, okay, or about equivalent to breast cancer. But if you use quantitative techniques, you actually look at growth. And growth doesn't mean it's cancer. It just means it's actionable for a diagnostic workup cancer. The best results for that published from ILCAP, published from the UKLS, the United Kingdom screening trial and stuff like that, are on the order of 3-4%. And that's unbelievably efficient for a cancer screening process. So false positivities, that should not be the leading factor either. Again, you can't go to a place that started lung cancer screening tomorrow with a bunch of people who don't know anything about lung cancer, because they could botch it and there could be false positives. But if you're talking about a place that has good interdisciplinary expertise and has trained its professionals correctly and is doing LungRADS, which we think really quite primitive, actually, relative to the techniques from quantitation that are going to be coming over the next decade, they can still get 12%. 12% is a very good number, and that's a very responsible number. And you're seeing, the diagnostic acumen from the Nelson that was published a couple of years ago. They're better than those numbers. And so this, again, is not a limiting factor. But again, you can't get away from quality delivery of the service.
Yeah, that was really well said, Dr. Mulshine. I think we've presented to a lot of different communities about lung cancer screening, and one of the biggest causes of hesitancy to get screened is exposure to radiation. But as you said, the amount of radiation that an individual is exposed to from a low-dose CT scan, as the name suggests, is very low. And you brought up the example of, just flying results in radiation exposure as well. And the amount of radiation that an individual is exposed to during a low-dose CT scan is not much different than, flying as well. So we really try to communicate that and get that across in our presentations and when reaching out to communities. But that's always, we've seen that it's always been a cause of hesitancy for people. And so we talked about at the beginning of the podcast the lung cancer screening guidelines that are set up by the USPSTF. And so those guidelines, just for everyone, those are very categorical guidelines. Individuals have to be between the ages of 50 and 80. They have to have a 20-pack year smoking history or more, and they have to be currently smoking or have quit in the past 15 years. And as we talked about, there are other risk factors for lung cancer that are currently not included in the USPSTF lung cancer screening guidelines. And so, Dr. Mulshine, based on your research and your expertise, what would the ideal lung cancer screening guidelines look like? And I know this is probably the million-dollar question in the field of lung cancer. So, but we just wanted to hear your thoughts on this.
Okay, thank you. This is a great opportunity, and I'm going to try to be efficient. Number one, we do want to. We just wrote an article that says, if the U.S. Preventive Services Task Force has just extended eligibility for lung cancer screening, and it involves 15 million people, based on NLST data published by Paul Pinsky, and David Gerard and others, and then LCAP data published by David Steiger and others. You now find somewhere between 35 and 35% detection of emphysema of some level in all those screening cases. Of all the people who are screened, a quarter to a third have findings of emphysema. And we know from the literature that that degree of emphysema seen in lung cancer screening setting is associated with an increased frequency of developing lung cancer. And it's also associated with increased chance of death, premature death, okay? So if you're finding that routinely in lung cancer screening, you have no right not telling that to people, because people need to know if they have these other things. For the simplest reason is because, many people getting screened now still smoke cigarettes. And if you have emphysema and you're at increased risk of getting lung cancer and you're still smoking, it gets worse. The risk keeps going up. So this might be an extra motivation to stop smoking. So there's no reason not to tell people. Well, the U.S. Preventive Services Task Force hasn't said a word about that. And guess what? For every one person that's diagnosed with lung cancer in the screening cohort that's eligible right now under their guidelines, 20 times more people will have emphysema. Well, what kind of screening is it? The U.S. Preventive Services Task Force has to acknowledge this, and they have to deal with it. And, I don't mean to beat up on the U.S. Preventive Services Task Force. They do a phenomenal job, and they got to be experts about everything. And God only knows how complicated their job is. And I appreciate their willingness to serve the public in what they do. But in this case, they got some work to do. I worked with a group that was communicating with the CMS, and the CMS group involved with developing the second revised national coverage decision about access to reimbursement under CMS provisions. Okay, and there's about 6 of us. Alec Hazaruni from American College of Radiology, the surgeons from the ATS and stuff like that. It was a great group, Mayfield and others. And we were very concerned because, like, for instance, stopping screening because someone's stopped screening more than 15 years ago is an arbitrary distinction. First of all, it's very hard for EMRs and stuff like that to establish that when that, and because pulling all those elements together in the EHR is, I don't know why it should be, but it's difficult. And from a epidemiologic perspective, there's no drop off in risk at 15 years. There's plenty of people that get lung cancer 16 years after smoking cessation, 18 years after, 22 years after smoking cessation. It doesn't drop off. So why does U.S. Preventive Services Task Force endorse something like that when there's no objective evidence? That's not their charter. They have no business doing that. So we had a very animated discussion about that particular point. So we think there's some work around the edges on these things, okay? But the fundamental thing, and you guys won't be surprised from our previous, few minutes here, is that emphysema detection is coming. Artery disease is coming. Coronary artery disease, risk related to coronary calcification is already in the guidelines of the American Heart Association, American College of Cardiology. Okay, it's already in their lipid management guidelines. And I just heard from an investigator who I can't name in Europe, who's renowned, who's just looked at the first 1,000 people they screened for the big three. They're doing formal lung cancer, COPD, and cardiac screening. And it turned out 30% of the people that they were screening who were on statins had no coronary calcium. And so they had other, lipid or cholesterol parameters that caused the prescribing of a statin, but their coronary circulation was clean. So their risk of atherosclerotic heart disease was minimal. So in most instances, most professional societies would stop the statins. So in that European experience, with the first 1,000 people stopping statins in the 30%, reduce pharmaceutical costs in excess of what it cost to do the trial. So they could pay for the cost of doing the research just by reducing the unnecessary prescription of statins. Now, conversely, they did find some people who had more coronary calcification than they should have had by their, by their Framingham index or whatever, and they had to start statins. And now the question is going to be, when they do the trials, what is really the cost benefit there? And that's an issue that has to be resolved. But so you can see that guidelines are fluid, and they're a function of us getting smarter about where technology gives us an, and then trying to put that information together in a responsible way, so that we can then distill from that clinically actionable management, stopping something, starting something else. So I think you're going to, through the rest of your professional lifetime, you're going to see an evolution of this. You're going to see, just to be provocative, 10, 15 years from now, they might do a thoracic CT on every 40-year-old just to see what's going, because, the average person doesn't get disease. It's the outliers that get disease. So if somebody has a cryptic case of alpha-1 antitrypsinase deficiency, or this or that or the other thing, you may miss all that. But if they have lungs that have, evidence of scarring with calcifications, that chances are those people are not typical risk people, and they merit some further consideration. What that is, I couldn't say to you, but we're going to use this information much more broadly because it's safe and it's relatively inexpensive. And the question about managing it, so don't do a lot of overdiagnosis and overtreatment, is something that, with pragmatic trials and various approaches that we now are very familiar with, we can keep evolving this towards better efficiency and better outcomes. And that's good for jobs.
Thank you, Dr. Mulshine, for sharing your thoughts on that. Like you said, the USPSTF did expand its lung cancer screening guidelines in 2021, which resulted in increasing eligibility for lung cancer screening to around 14 million individuals. So that was definitely a step in the right direction. But as you brought up, with individuals needing to have quit with smoking within the past 15 years, I think that criteria can definitely bring some limitations, because, for example, an individual who has a 30-pack year smoking history but has quit for more than 15 years might, still be at high risk for lung cancer. And likewise, an individual who has a heavy pack year smoking history but is 81, for example, and has just passed the age criteria for screening, they'll also be ineligible for screening. So I think those were some really important points that you brought up. And so in your work, you look a lot at how we can ensure equity in lung cancer screening. So can you talk about how we can increase equity for screening in the coming years?
Yeah. So I think thank you. This is a very key point. So I said we had a paper where we said, you're going to find all this emphysema and what are we going to do about it? And so part of the pushback we got was, well, if you have coronary calcium, you can start statins or you stop statins. So we should do that right away, this, that, and the other thing. And I'm not trying to beat up on anybody, but a lot of what we call health and public health is or is not driven by pharmaceutical marketing and imperatives and stuff like that. And so for somebody who has modest emphysema discovered on a CT scan done at age 50, and 85% of these people have no idea they have anything wrong with their lungs, okay? Our position is, hey, just tell the person that just exercise. I'm just going to focus on physical activity. Can reduce your cardiovascular risk, which is the leading cause of death for people with emphysema. And it might improve your mechanics of respiration, because part of the problem of breathing correctly is the fact that as you get older and you get a little shorter breath, you do less exercise, you decondition, and your axial skeleton is scaffolding less efficiently because you're hunched over, you don't have full excursion of the respiratory cavity, and the balloon doesn't work as well. And so to the extent that you walk and do very modest exercise and you preserve the intercostal muscles, the axioskeletal muscles, you really can improve and sustain the efficiency of respiration in meaningful ways. These people, in many studies have shown they feel better. Now, trying to prove that they actually objectively are better is really hard. And that's why we're really excited about quantitative analysis of these imaging parameters, because it's going to objectively show this works or this doesn't work in ways that we're going to become more comfortable with. But the idea that we can lock these early changes, whether it be for heart, lung, or whatever, based on thoracic CT, and link them to physical activity, smoking cessation, improved diet, getting better sleep. So on preventive measures, getting your schedule of immunization, we can potentially make the world a much better place. We're not going to wait till people get sick and need lung volume reduction surgery or advance this or advance that. They can do simple things that are already paid for as national preventive benefits, and just live lives without the constraints of shortness of breath and all the trauma of end-stage cardiovascular disease and emphysema. So the idea of using thoracic CT to engage, social determinants of health in a more adaptive way and get us an objective tool to coach people about the benefits of increased physical activity, that's very inexpensive and could be applied across all reaches of our society tomorrow in a much more productive way than it is today. And that's equity. That's allowing more people to live better, healthier lives. And it comes from objective information seen from this annual evaluation of this very high population, that right now, the mortality from the 3 diseases that I just discussed exceeds the next 28 causes of premature, that it exceeds the sum of the next 28 causes of premature death in our society. So this is big numbers. So if we can use thoracic CT, develop a much stronger sensibility of routine preventive measures as we age, that is a big win for equity.
So this is going to be our last question, but we often get questions about the impact of e-cigarette use on lung cancer risk. So could you tell us whether there actually is a link between e-cigarettes and lung cancer? Has it been found? And how do e-cigarettes actually relate to tobacco cessation?
So do we have another hour? So the 2-minute version of this. E-cigarettes theoretically are delivering nicotine without the combustion products and all the manifestations of dirty tobacco, okay? So theoretically, that should be a good thing. And there are some very serious public health people that are trying to use it with very highly addicted, tobacco-exposed populations to try to help wean them from their smoking habits, because, as you know, chronic smoking is an incredible addiction that's very hard to break. And the data to date has not been overwhelming that it's successful in that regard, but there are some articles that suggest there are some benefits. But the way it was, e-cigarettes were presented in our country was that, your favorite flavor of everything was available to every 15-year-old in the country. And, I can't keep track of the unbelievable penetration that e-cigarettes have in the young people in our country. And basically, there's a certain phenotype that become addicted very rapidly to cigarettes, and there's a certain phenotype that gets very addicted very quickly to e-cigarettes, because nicotine is, and some people utilize it in such a way that it's incredibly addictive, okay? So when you expose a vast population to nicotine products, through the rest of their lives, it's fluid whether they stick with e-cigarettes or that's a pathway to full cigarette smoking. So e-cigarettes are a dangerous vector of potentially sustaining tobacco exposure eventually. And that's why in the United States there's such a visceral response to this. But apart from all that, because the FDA is just now getting involved in the regulation of the manufacture of e-cigarettes and stuff like that, a lot of them are made by fly-by-night organizations that who knows how they make them. And there's not real care in terms of the purity of the composition of stuff in the outflow that's going to come out of the devices, and there's not scrutiny around how the devices are made and this, that, and the other thing. And it turns out there's lots of contaminants in these things, and it's very dangerous, and you're throwing them right into your lungs. So there's a whole variety of issues, and that's 2 minutes. And so I can't say much more, but it's a very complex issue. But putting nicotine into the lungs of 15-year-olds does not sound like a great idea.
Yeah, thank you, Dr. Mulshine. The reason we ask this question is because we get this question a lot, especially from students when we present to schools. And as you said, it's really unfortunate, but the use of e-cigarettes and vaping in general is increasing, especially among young adults. And so, because it's a relatively new phenomena, we don't clearly understand the long-term effects of e-cigarette use and vaping. And so it's just, it's really scary to think about the potential effects. And I know there's still a lot of research being done, but some preliminary studies have shown that, especially for individuals who have never smoked before, the use of e-cigarettes and vaping does increase lung cancer. So thank you for that. But with that, I think we can go ahead and wrap up our podcast. I'll hand it over to Drake. Thank you again so much, Dr. Mulshine, for your time. But Drake, I'll hand it over to you.
Thank you, Priyanka.
Again, thank you so much, Dr. Mulshine, for your willingness to share your wealth of knowledge and perspective on many of the pressing issues in the lung cancer world. We appreciate all the work and research that you are currently doing. And we also would like to thank everyone for listening to our podcast. Please keep an eye out for upcoming podcasts and events, which will be listed on our website, www.alcsI.org. Next week, we have podcasts with Dr. Emily Stone and lung cancer survivor Carrie Mitchell. Zoom registration and information on these individuals can be found on our website under calendar events or our Instagram bio. Thank you and have a great day, everyone.
My pleasure, my privilege. Thank you.